Hi, Ben.
Hi, Daryl.
Hi. Thanks for being part of our conference today. Good to see you.
You're very
Uh,
welcome.
yeah, and I'm in New York. You're in Manchester, England, and our audience is all over the world. So we're happy to be gathered here today. Can you tell us what you do and where you do it?
Yeah, sure. Um, where to start? I don't know if people are aware, but there is a major cancer centre based in Manchester in the UK called the Christie Hospital. It's been there for many years. It's the biggest cancer centre in Europe. I'm based at the Christie, and I've been there for 15 years working on living with and beyond cancer, survivorship, aftercare pathways, patient engagement, and all of that sort of stuff. Um, at some point during that journey, I picked up an interest around LGBT health and cancer, which kind of got attached to me, as these things often do when you're in professional environments. And that became a research interest and a kind of day-to-day service improvement interest, and so on and so forth. As part of that, we did something called an LGBT Cancer Support Alliance, which was around bringing people from different stakeholder groups around the north of England together to talk about what the needs of people affected by cancer were who were also LGBT. And that really got the ball rolling in the UK around this topic area. And I've kept that as one of my interests in my portfolio. As well as that, I do have a sideline and a small charity that I run called Arts for Health, which is in the south of the UK, and I do that remotely. And that's a completely different topic, although it does intersect a little bit with cancer and LGBT, because that's all around providing arts interventions for people with mental health problems and various other health concerns, and hopefully improving their well-being as a result. So it's pretty broad. I'd describe it as a portfolio career. I think that's the buzzword, isn't it, for this kind of stuff.
Very good, and congratulations on starting what sounds like a worthy nonprofit, the or NGO. The what do you prefer, NGO or nonprofit?
I go for charity.
Oh, excellent. Okay, so more complicated terms for everyone to know. It's the idea of an LGBT focused field around cancer. Even among the community, the question is why? I mean, isn't cancer applicable equally and treated equally for everybody?
Yeah, that's a really good question. And that is the question that you're faced with when you first start talking about LGBT and cancer to many cancer professionals, doctors, nurses, service managers, whoever it may be, a quizzical look. Why do I need to know your gender identity or sexual orientation in order to treat you successfully for cancer? And in order to answer that question, you have to, first of all, reconsider what cancer means to people who are affected by it so that it becomes something other than just a medical issue. Because to treat someone successfully for cancer, you have to have a holistic approach. And I'm sure people who are listening to this right now will fully agree with that statement, because it's definitely the way things have gone over the past 20 or 30 years. We now view cancer in a very holistic way. So therefore, when you have a care plan for your cancer treatment, you're going to be talking about not just your physical needs, but also your social, psychological, emotional, vocational needs, and so on and so forth. So when you take an intersectional approach like that, inevitably it's going to intersect with your identity. And when you're in a marginalized group like LGBT people are sometimes described as being in, then you start to have to think about health inequalities, because when you're in a marginalized group, there are health inequalities when you try and access services and your experience of services, and so on and so forth. And when you start to think about health inequalities, well, there are loads associated with being LGBT, and therefore they're going to intersect with cancer. So always frame the conversation around health inequalities, and always frame the conversation around how cancer is now being treated in a holistic way. And it will then become clear, the penny will drop when you speak to professionals as to why we need to think about sexual orientation and gender identity to successfully look after people and improve their outcomes.
When the organizations you've been affiliated with and your own personal work, when you go out in the community, when you sit around and or stand up, march in a parade or sit in a bar and you're chatting up with somebody and saying, um, "Oh, mate, you got prostate cancer. Here are some have you thought about this or that?" I mean, what are those kind of conversations like?
Well, everybody's cancer is different. Okay, so we talk about prostate cancer in a very kind of universal way. But I remember speaking to one patient who incidentally did identify as gay, and he said, "I have my prostate cancer. I don't have anybody else's prostate cancer, and then things that need to happen to me are unique to me." So whenever you have a conversation around, when someone discloses they've got prostate cancer to you, it's really important you don't start generalizing and saying things, well, this happened to such and such, this happened to such and such, this might work for you. You've got to try and see the person first of all. So what's happening to you specifically? What happened when you went into that first clinical discussion? What happened when you first had time on a ward, if that's appropriate? What's happened to you kind of emotionally and psychologically? And probe, probe a little bit, because they'll start to tell you about what's important to them. And that's what the conversation needs to be about. So that's the first thing I would say. The second thing is, when I speak to people around prostate cancer, they often worry that it's somehow impacting their sense of masculinity or their sense of being a man. And that's a common thread that comes out quite often around prostate cancer. And that applies very much to LGBT people as much as it would do to straight people, of course. But there might be other concerns that intersect with that around being LGBT that individual might want to explore with you. So that's something else that I think is often overlooked. This idea that prostate cancer kind of intrudes on masculinity in some way. And if you think about it, some of the side effects from prostate cancer, like erectile dysfunction, obviously speak to that, don't they? The idea that it's impacting your sense of being a man, your performance maybe as a man.
Yeah, and also lack of ejaculate. Do you think missing ejaculate affects gay and bisexual men and men who enjoy having sex with other men in a
Yeah,
way that's
definitely.
different?
Mhm.
Well, it certainly affects them, but in a way that's somewhat different than for straight guys.
Again, I refer back to what I was saying about it being unique to each individual. I wouldn't want to generalize too much on that, because there's a large variety of sexual practice amongst gay and bisexual men, and some people would put more emphasis on perhaps the ejaculate than others, depending maybe on what their sexual role is. So again, it's, I wouldn't want to generalize, but yeah, I mean,
Yeah, no, fair play. I mean, because
sort of,
part of the difficulty of conversations like this is how far you can generalize. When we
mm,
know that, I mean, every patient is unique. Otherwise, we wouldn't need doctors. We just go to the pharmacy or go to a gas station or garage
mm,
and say, do some robotic surgery while you fix the brakes. I mean, it's like we're seeing doctors because we need a specific way to address both our anatomy and the challenges to our anatomy that cancer cells pose. And then understand that within the context of who we are, what our goals are, what our age is, what our economic capacities are to pay for things that can fix us, a
yeah,
whole host of things. Um, but with around LGBT stuff versus straight stuff, I mean, there are generalities that can be made. Perhaps the clearest are around access to care and barriers to care. What's it like in the UK? And what do you imagine might be similarities or differences between the UK and other developed countries around gay and bisexual men's ability to access appropriate care?
yeah, it's a really good question, because obviously in the UK we have healthcare that's free at the point of access on the NHS, and obviously a parallel service for people who do have health insurance if they choose to take it. Um, there are capacity challenges at the moment in the NHS. We do have a lot of people needing support and services that, you know, without wanting to get into political hot water, have perhaps been underfunded for quite a number of years. And, you know, we could really do with some more doctors and nurses to help the system move along. Again, I think if you're going in with a specific medical issue and you have access to a clinical pathway that you're on, you're going to get really, really good care. But it's challenging getting through the door in the first place. Waiting lists are a problem, and how this intersects specifically with gay and bisexual men, I think, often is to do with how they've been treated previously by other doctors at different points in their life. So, for example, if you've had a poor experience of care when you were younger, you are perhaps less likely to access care when you're older because you're worried that you might encounter discrimination. It's that anticipation of potential discrimination that can prevent people coming forward. And therefore, you know, as we all know, cancer is a disease that requires an early diagnosis in order for it to be curatively treated later down the line. If you're presenting later, then that's less likely to happen. And it's a real shame that people who have encountered, you know, discrimination from healthcare staff in the past are then reluctant to come forward when they need to, when they're faced with cancer. And I think that's a big issue. Another thing that I think is very striking is you very rarely see gay and bisexual men represented in campaigns, you know, public information campaigns around prostate cancer, although that is starting to change, I'm pleased to say. And, you know, when we talk about representation, it's really important to see yourself in campaigns and publications so that you know the signal is there that this service is for you. And if you never see a gay and bisexual man in the context of cancer care, then you could probably drift along quite happily and never think about cancer. And then you'll never know what the signs and symptoms are. You'll never know when to come forward. You'll never know what the risk is. And perhaps you'll think those services aren't for you and you'll just back away. And I've heard lots of stories about both of those two issues where people have encountered discrimination previously and don't want to come forward, and where people haven't seen themselves reflected in the marketing and therefore haven't come forward either. And particularly around bisexual people, I mean, we often refer to them as the invisible group, don't we? Because even amongst our LGBT projects that we've done in the past, you could argue that a criticism of those would be to kind of leave the bisexual people to the end, and not bring them along with this journey, because, you know, I think with people who identify as bisexual, and that's not me, so I don't want to speak for them, but you could argue that there's less pressure to come out to healthcare professionals, and you can be invisible in that way and never have to disclose your sexuality. And perhaps that's an issue. Perhaps we could do more to support that group as well.
Yeah, and we'll get into coming out to doctors shortly. The But it's worth noting, you know, we're not when we started Malecare 22 years ago, 23 years ago, we used the phrase LGBT. When we started the National LGBT Cancer Project, that was 2002, 3, or 4, where, you know, it took a couple of years to ramp up, but I mean, that was LGBT. Now we're more inclusive, more aware, and more, you know, validating, and by including LGBTQ plus and
Hmm.
LGBTQA plus and LGBTQAI plus and
Hmm.
on and on. And, you know, it's, to an outsider and sometimes to, you know, people in our field, it's a bit whimsical, you know, to a point. You know, how many letters will we add on? But there are indeed non-binary people. There are indeed gender wondering people and gender, you know, uh, people of I just forgot the phrase, but the idea of being not committed for whatever personal reason you have to a particular gender,
Hmm.
the intersex people, and then of course transgender people have their own unique kind of subcohorts, you know, subcohorts. Um, the idea of being inclusive is extraordinary in that it includes but it also sort of muddies the water around activism, because then people will say, "What, you're including a panoply of people." I'll let the audience use their own minds to say that correctly, but the idea of diluting what may be a powerful opportunity for activism gets in the way. What drives change in the UK? You mentioned that signage and
Mm.
visibility of gay and bisexual men in prostate cancer literature is increasing. What's driving that?
There's a lot more people who work in health who are out as healthcare professionals, and that is a massive driver towards improving care for LGBT people. Because as a healthcare professional myself, I want my own community to be looked after. Of course I do. And because I have lived experience of that community in a professional environment, I can bring that to the workplace. And there's lots of people like me who I think have realized there's an opportunity here to improve matters by bringing that lived experience to the table. The other thing is the opportunities for training and education around LGBT and cancer have improved enormously. And incidentally, the first thing we do in that training is to demystify all those letters that come on the end of the LGBTQ plus, and all the rest of it. And you often hear healthcare professionals who perhaps don't have any lived experience around the LGBT community give out a big sigh and say, "Gosh, I'm so worried about mislabeling people or getting it wrong or putting people in the wrong box or stereotyping somebody." And I always say to them, don't worry about it. You can't be expected to know every detail about every single minority group you're going to come across as a healthcare professional. It's just not a realistic ask. So therefore, just go in there with curiosity. And if you do make a mistake, the individual in question will probably say, "Hang on, my pronouns are whatever, and this is how I identify." And you just say, "Thank you very much for letting me know that. Make sure it's in the clinical note taking, and Bob's your uncle, problem solved." What you don't want to do is go into the next consultation and see the same person and make the same mistake, because then that just annoys people, and so on and so forth. So yes, it's okay to ask. Yes, it's okay to be a bit anxious about it. But once you've got that information, you need to make sure you use that information once it's being offered. But yeah, people get very concerned about misrepresenting people for different reasons. Another thing that's driving change in the UK is the very active number of LGBT related charities that we have operating across the country. So I'm sure you've heard of Stonewall. We have a big charity in the UK called Stonewall, but there are others that are smaller but equally as active. For example, the LGBT Foundation based in Manchester, which is just down the road from where I'm sitting right now. They've been extremely active and allying themselves with different healthcare organizations around the city to push that agenda of change across the whole of the sector, because obviously it's not just around secondary care, it's also around primary care and community-based services as well. So the whole system needs to move together. And sometimes when you have an organization like the LGBT Foundation that can coordinate, it's very, very helpful. An example of that would be for the LGBT Cancer Support Alliance, which was one of my projects. We didn't want to set ourselves up as a charity and go through the rigmarole of having a bank account and all the rest of it. So you can lean into organizations like the LGBT Foundation who can take that burden off you, and they can look after any monies that need to be sorted. They can deal with any legal issues. They can provide a venue. They can provide tea and coffee. They can provide information and support, perhaps a bit of web space, whatever's required. They can do that for you, and that frees up clinical people who are healthcare professionals to actually work on delivering what needs to be delivered. And that capacity building has been absolutely instrumental in moving things forward, and that's still going on. Funding is always a barrier. Quite a lot of this has been done on the free, which is very challenging for people. It would be lovely if we could actually pay people to be LGBT and cancer professionals. We did dabble with that at one stage, but things as they are mean that's quite difficult to sustain. But again, that's has happened and it has worked well in the past. And then the other thing, of course, is patience. And it's really important to value the contribution that patients have made to delivering change over the past sort of decade, because people who come in and are willing to tell their stories to camera, a bit like we are doing now, and be a point of contact for others, perhaps provide peer support, set up peer support groups, that sort of thing. There's been quite a number of individuals that I can think of who have been brave, who have put their vulnerabilities on the table and said, actually, I'm going to be an advocate from the community. I'm affected by prostate cancer myself. I identify as a gay or a bisexual man or a transgender woman, and I'm going to put myself out there. And that's been absolutely fantastic. So fair play to all of those people. We couldn't have done it without them.
No, that's brilliant, and it leads into the final sort of 10 minutes of our discussion, which I think many people are looking forward to. You know, what does it take to be out, both as a man diagnosed with prostate cancer, as well as perhaps a gay, bisexual man, a non-binary man, or a transgender woman?
I mean, I tell you what, coming out is not something you ever do once. Coming out as a gay and bisexual man or a transgender woman is something you have to do all the time. And you always have to make that decision, don't you, when you meet a new person, professional, personal, or whatever context. Do I tell this person? Do I mention it, or do I just let it lie? Do I just carry on and never mention it? And you have to make a calculation, don't you? Am I going to get a poor response from this individual, or am I going to get a supportive response from this individual? And I'm sure we've all been there. And when you go into a clinical environment and you meet your doctor, your healthcare team, you have to make that same decision. Am I going to come out to my doctor today? Will my doctor remember next time I come to my appointment that I came out last time, or will I have to come out again? Am I going to meet a whole bunch of different professionals this time because I'm a different part of the pathway? And am I going to have discrimination? Am I going to have a poor response? Now, there is statistics out there that have been compiled by Stonewall and various others that suggest there is still quite a lot of discrimination going on in the system. And that's been reported not necessarily through NHS channels, but through other channels where people have been asked about their experience. Yes, I have encountered discrimination from healthcare professionals, particularly if you're identifying as trans or non-binary. That seems to be quite rife generally at the moment. And I think that is probably a symptom of how society at large is not dealing well with equality, diversity, and inclusion as regards to the trans and non-binary community at the moment. And I wouldn't be surprised at all if an individual received a prostate cancer diagnosis and didn't want to come out to their treating team. But the positive news is, as I've already mentioned, there is a lot of change going on. There's a lot of need for people to put their vulnerabilities on the table and say, actually, I'm here, I'm queer, and I want treatment. And if you do encounter some problems and concerns, there are people around who hopefully can help resolve them. And please go into this without fear if you possibly can. And another thought that's just popped into my head, of course, I mean, LGBT communities are highly sexualized communities, aren't they? I mean, we're talking about sexual orientation, first of all, as a baseline, but beyond that, it's almost as if the only health concerns that LGBT people ever face are sexual health concerns. We're going to be forever associated with HIV. We're forever associated with trips down to the clinic because people have had a big night out and slept with loads of people. Apparently, we're all incredibly sexually promiscuous all the time. If you were a straight person looking through the window into the LGBT community, quite often that is what you might see. So to go through life and then find yourself affected by prostate cancer kind of takes you out of that and puts you in a different space as an as a gay and bisexual man. And I think that is really challenging for people. I mean, okay, I've put my card on the table. I'm probably not old enough yet to be affected by prostate cancer, but I do wonder whether that is something that many gay and bisexual men face. You know, all of a sudden you can't go out and have multiple partners, and perhaps there's a risk associated with that, or you don't want to do it. You don't feel sexual anymore. Do you see what I mean? The sense of sexual self has changed. And I wonder if that's a problem for people as well. I'm riffing slightly there, but
No,
You know.
good. We're there's a small group in our audience, a virtual audience that I could hear in saying, "You are too young enough to have prostate cancer." One of our board members was diagnosed and treated at age 32, 32, 33. The youngest person in one of our support groups was 27. So
I
and
take
we
it
have
back, that comment.
yeah, get your PSA checked and that whole thing. But the idea of coming out and coming out and coming out is a challenge that straight people don't face.
Yeah.
Um, you know, uh, Racial minorities wear their minority on their skin, on their face for the most part.
Mm,
Religious minorities to some degree, to some extent. Uh, Geographic minorities, almost always the minute you open your mouth and say anything by accent, or
mm,
by,
mm,
just the kinds of things you say. The idea that um, gay and bisexual men who enjoy sex with men are easily identified, that gaydar, gay radar,
mm,
is something that we all possess, is almost nonsensical unless you're particularly out in an extreme presentation, of, almost a fantastic presentation of what you think gayness is about and what you feel
mm,
comfortable being as, which is fine. But for the most part, nobody really can tell for sure. So it becomes incumbent to be out if indeed you find being out critical for your health care. Can you tell
mm.
us what do you think are like the top 1 to 3 or 1 to 5 ways that being out is critical to cancer care and perhaps specific to prostate cancer care?
That's a good question. I think one of the main things would be accessing peer support. Um, I think it's really important for men affected by cancer and trans women to find appropriate buddies and peer support groups to help them, particularly post diagnosis, going through treatment, and then into the recovery phase of cancer, or possibly into palliative care and end of life, of course. And time and time again, I've heard stories about gay and bisexual men accessing, shall we call them, mainstream peer support groups, and encountering homophobia from other patients and members of that group for whatever reason, and they've pulled back. And I think it's really important for that support to be available for people, and it needs to be tailored to that particular group, because as a gay and bisexual man affected by prostate cancer, you are probably going to want to talk about sex and sexual function and what's going on down there. And you don't want to be encountering homophobia when you're trying to ask questions around that and chat about that, because how embarrassing, it would be awful. So, yeah, access to peer support. Now, how do you access peer support? Well, normally you're going to be signposted by a healthcare professional or somebody orbiting that kind of professional group. And how are they going to know you're LGBT if you don't tell them? So it's really important to come out. You can then hopefully be supported to access peer support and other people who identify the same as you with the same issues. And fingers crossed, that will be great and be very productive and improve health and well-being and general psychological and emotional recovery. Brilliant. And of course, you'll make new friends. I mean, again, time and time again, you hear about people who've gone through cancer and they're like, oh, I've made a new friend because we had the same diagnosis and we went to the same clinic. And actually, some positive things do come out of having cancer, and that's one of them. That kind of sociability, that connection with other people who might be encountering the same problems. And you don't want to let homophobia and transphobia get in the way of that, that's for sure. And then you might need specific advice around things like, is it safe to have anal sex after radiotherapy to the pelvis? So that kind of medical advice is only really going to be offered to you if your healthcare team know your sexual orientation. You might be dying to ask that question, but you don't want to come out. for whatever reason, and then you will never hear the answer. And that information does exist. There is a research project done by my colleague, who's a chief radiographer, I think, over in Leeds now, which is the other side of the country. He's done a research study about whether it's safe to have, at what point is it safe to have anal sex following radiotherapy to the pelvis, and of course that's the kind of information that gay and bisexual men affected by prostate cancer might want to know. What else have we got? Yeah, I think that's fine, actually. Yeah, I think they're the two biggest issues. You need appropriate medical advice and access to peer support. They're the two things that I hear the most.
Yeah, and that's more than reason enough. I would suggest a third is that you get a better sleep at night. That whatever you're wondering your doctor may be thinking, you've now dispelled that by being out to them. You don't have to wonder anymore. They know, you've told them that you're whoever you are, and the hope is they'll treat you appropriately without homophobia or any kind of thing. And if you felt comfortable being out to them, chances are your gut told you that was a cool doctor to come out to, and if it turns out it's not, good for you. You found out earlier rather than later that it's time to switch your consultant or your doctor, and to the extent that you can, because obviously some people don't have the wherewithal to do that because they're in a rural area or don't have the economic means, etc. But for many people, if the opportunity presents that you could get a better experience with a different doctor, go for it. You'll never know that if you don't say who you are. I mean, you're saying your Gleason score, you're saying your PSA, you're saying, your PIRADS, and on and on and on. I mean, how much more intimate do you want to be with another man?
Well,
So,
exactly. I mean, we seem to be more willing to talk about penis and testicles and buttholes than we are to talk about sexual orientation. And when you work in cancer, you get used to talking about anatomical issues. But I think as a patient coming in, it's like, oh my goodness, do we have to talk about this today? And it's like some barriers need to come down, don't they? But you're absolutely right around peace of mind, and you've just reminded me about the concept of minority stress. I don't know whether our listeners will be familiar with that one, but the idea that when you're in a minority group, your kind of background stress level is a few percentage points higher than people who might see themselves as being in the mainstream. And you have this, it's a bit like background radiation. You have just this marginally higher stress level at all times, and that's your natural baseline, because you're constantly on high alert for, should I be coming out to this? Is that person gonna discriminate against me in some other way? Am I going to see something homophobic on TV tonight? That kind of idea, and you just get used to it. And this is kind of minority stress. And of course, when you go into crisis, you're suddenly affected by cancer, or there might be a financial hardship, or you might lose your job. And because you've already got a high baseline of stress, it's much easier for that stress level to tip over into a problematic situation. So you're more likely to find yourself having emotional and psychological problems because you've got a higher baseline stress to start off with. And of course, if you're not out to your clinical team, then surely that stress level is going to inch up just that little bit more, because you have to watch yourself when you're going into those appointments. I don't want to let it slip. I don't want to say something that might make them think I'm gay, whatever it is. Suddenly your stress level's up a wee bit higher. And just coming on to the issue of trans women for a moment, as we know, trans women retain a prostate and therefore are at risk of prostate cancer. Prostate cancer clinics are generally full of men. And as a trans woman coming in and just sitting in the waiting room, you might present as a woman. Well, you would present as a woman, wouldn't you? So in a room full of men who might be looking around thinking, what on earth is she doing in here? That's going to raise stress levels much, much higher. And I do think there's an onus on prostate cancer service providers to provide some safe spaces for trans women. And the problem is always, the kickback is always, oh, there's not many of them. and we haven't really got the room, and we can't reorganize our clinics around 1 or 2 trans women that might be coming in, every 2 years or whatever it is. But at the same time, it's a terrible experience for trans women affected by prostate cancer to be thrust into this male environment. It's just a constant reminder that they were born male, surely. So, I think there's a lot of work to do around supporting trans and non-binary people.
Very well said. And we have a number of presentations during our conference for trans and non-binary people, and we go into deeper depth on that. I hope our audience will take the time to view those as well. Ben, thank you very much for today's conversation. I know our audience will be delighted to have heard you, but also we'll get some helpful hints from listening and having sat through this opportunity to hear someone from who's both an activist and a local of Manchester. So certainly fans of Shameless will enjoy having met you today. And, you know, we won't get into Manchester United versus City, and we won't.
I'm actually looking at Manchester City's ground from my flat right now.
Oh,
I can see it.
wonderful.
Just there. And actually,
Okay.
it's quite sunny today,
Yeah.
which is a nice surprise.
Well, so you could see the pitch from there, from where you're
I
sitting?
can't see the pitch, but I'm looking directly at the stadium. It's about half a mile away, just over there. I'm on the 17th floor here, so I get a really good view.
Oh, wonderful. Okay, well that's very cool. We'll talk about that another time. But all right, thanks for being part of our conference. Welcome to Malecare's faculty. You're now part of our, historic multi-hundred member faculty, and we're very pleased to have you be part of our conference.
That's great.
Cheers.
Thank you for having me.